Good morning. Today I have the pleasure of introducing Dr. Scott Jordan. Dr. Jordan is a gynecologic oncologist with the Broward Health System in Fort Lauderdale, Florida. Dr. Jordan completed his residency at Temple University, followed by a fellowship at the University of Miami in gynecologic oncology. Dr. Jordan has been involved in multiple clinical trials investigating the latest research in this field. Dr. Jordan is currently a clinical assistant professor at Florida International University. Dr. Jordan, take it away.
Thank you very much. Thanks everybody for joining us this morning. Everybody can see my screen, hopefully. We're going to talk today about precision therapy in gynecologic cancers. And I'm going to make sure that my stuff is working here. I have no relevant disclosures. So I wanted to talk about what does precision therapy mean. So to me, this is, and also to the FDA, this is targeting the right treatments to the right patients at the right time. I think it's this sort of broad, we always talk about personalized medicine, precision therapy. We kind of throw these impressive sounding words around, but really we do try and personalize our care for every patient. We try and take into account their lifestyle, their genetic makeup, and their environment into our treatment planning, not just as we're choosing therapeutic agents, but also as we're planning surgery. So with that in mind, what I wanted to talk about today, I wanted to start by talking about how we can have precise and precision therapy in the surgical space, and how we can use minimally invasive surgery, sentinel lymph node biopsy, and minimizing the surgical morbidity in patients with gynecologic cancer. So when we use precision care in the surgical approach, our goals are to minimize pain, minimize recovery time, minimize surgical risks, and we want to do this all without a compromise in oncologic outcome. So we try and prioritize as much as possible a minimally invasive approach. And this is a picture of traditional laparoscopy, both from the outside and the inside. And this was invented early in the 20th century with roots going back as far as the early 19th century. And the first laparoscopic hysterectomy was performed in the 80s. And we've sort of advanced from there. This picture to the right is a traditional straight stick laparoscopic hysterectomy, what it looks like to us on the video screen. On the left there, you can see the surgeon standing around with port sites, the small incisions that allow us access to the abdomen. In 2005, I guess I have recent history on here, but I guess 2005 is not all that recent. The Da Vinci robotic surgical system received FDA approval for gynecologic surgery. It had first been released in 1999 and 2000, receiving various approvals for various surgical indications. This is the original Da Vinci system, the S, and you can see how massive that surgeon console is, how unwieldy the patient cart with all the arms that attach to the patient are. So this is what we use now. This is the Da Vinci Xi. It's about 7 years old. Really makes this an easy process, the docking process, attaching the robot to the patient. It makes the port sites smaller. They're all less than a centimeter. And we're able to operate in multiple parts of the abdomen without undocking and redocking the robot, which is really cool. And the surgeon console on the right there of that picture is where we sit as we're operating. And you can see it's a lot more slimmed down, modern looking. This has 1080p HD 3D vision so that we can see very, very well what we're doing. And in the next iteration, we'll have 4K vision. So this is a really cool tool to use for minimally invasive surgery. So where is this used in gynecologic oncology? So this is in 2009, the LAP2 study written by Joan Walker and others sort of paved the way for us to say, okay, for endometrial cancer, it is, for one thing, safer as far as post-operative complications, a shorter hospital stay, but there's also no change in oncologic outcomes. There's no change in the 5-year overall survival of these patients, whether they get an open hysterectomy with a big incision or whether they have a laparoscopic hysterectomy. So that paved the way for us to begin offering our endometrial cancer patients, which often have a lot of comorbidities like obesity, heart disease, high blood pressure, diabetes, just because these are also the risk factors for endometrial cancer. These are patients that aren't often great surgical candidates for open surgery. So this offers a much safer route to removing their primary cancer site. So minimally invasive surgery for endometrial cancer, it minimizes the incision size. Like I said, often in patients with multiple comorbidities, it minimizes the hospital stay and recovery time, minimizes pain, and similar oncologic outcomes. But what about cervical and ovarian cancer? Endometrial cancer is our most common cancer, but we also treat these other disease sites. Well, unfortunately, although everyone expected that the minimally invasive approach for radical hysterectomy performed for cervical cancer would be equivalent, and this was performed very widely as essentially a widely accepted standard of care, a similarly designed trial to the LAP2 study, which was a randomized controlled trial which randomized patients to minimally invasive versus abdominal radical hysterectomy for cervical cancer. This was released in 2018. And it demonstrated that patients who had minimally invasive approach to surgery for their cervical cancer did worse. They recurred sooner, they died sooner of their disease. So this really put a stop to doing robotic and laparoscopic radical hysterectomies for cervical cancer. A meta-analysis published in the same, well, this is actually a later meta-analysis, but there were multiple meta-analysis, multiple large population studies, multiple small institutional trials. Those were all put together in a meta-analysis, which was released last year. And you can see that the diamonds at the bottom of the forest plots here demonstrate that outcomes are better, risk of recurrence or death favors open surgery when you put all these data together for both all-cause mortality and risk of cancer recurrence or cancer-specific death. So really, minimally invasive surgery isn't actually an option for cervical cancer. So despite those short-term advantages of minimally invasive surgery, the standard of care is really an open approach. And what about ovarian cancer? In our practice, we still plan almost everybody for a large open surgery because of the potential for spread all over the abdomen. A lot of times we're needing to extensively resect, not only do the hysterectomy, but also extensively resect omentum, which is a large fat pad over the intestines. Sometimes we're taking out the spleen. We're ablating or resecting part of the diaphragm, possibly doing bowel resection. And really, the feeling is that you're not able to extensively evaluate somebody surgically and be completely certain that you have removed every bit of tumor, which is the goal with ovarian cancer surgery, without having a vertical midline, a large incision. One thing we do laparoscopically is we evaluate the feasibility. So before we subject a patient to that large incision, we'll do a small incision, looking around with a camera and decide whether or not we're going to be able to remove all of the tumor safely. One caveat or possible consideration for this is that if you start with chemotherapy rather than surgery in your treatment for ovarian cancer, and almost all of the tumor is gone, at the time that you, and almost all the tumor's gone at the time that you're done with your neoadjuvant chemotherapy and you're ready to take the patient for surgery. If you feel that you're able to get all of the disease out with laparoscopy, it is possible to consider a minimally invasive approach to get rid of that residual disease. But you need to have a low threshold for conversion to open surgery. There is a current randomized controlled phase 3 trial evaluating the oncologic efficacy of this approach, minimally invasive interval cytoreduction, compared with open surgery. So we'll know, similar to the other disease sites, what the efficacy is there and if this is a reasonable approach. Now, sentinel lymph nodes, this is another side of our surgical management of patients in multiple disease sites. We do these in vulvar cancer, we do these in endometrial cancer, we do these in cervical cancer. And essentially, sentinel lymph node evaluation is when we inject some sort of a marker, a dye, a radiocolloid into either the primary tumor or the lymphatics of the primary tumor, and we look to see where this dye goes, what lymph node this dye goes to first, so that we're only taking out the highest risk lymph node instead of removing, say, all of the pelvic and periaortic lymph nodes. This decreases significantly the complications compared with complete lymphadenectomy. It also decreases the surgical risk of performing an exhaustive lymphadenectomy. And because we look at these single high-risk lymph nodes so much more carefully, there's actually an increased sensitivity to detect metastatic disease in the highest lymph node. And it's able to be used not just in low-risk endometrial cancer, but we can use it for the higher-risk histologies. We do have to have a negative preoperative CAT scan for locally advanced disease, demonstrating no obvious metastatic disease to the lymph nodes. But this is a great way to evaluate safely the lymph nodes. And this is what this looks like with the robot. This is a surgery I did a couple months back, and this is the pelvic sidewall. And we have this immunofluorescent dye that we're able to use near-field infrared technology, and it's pretty cool. It lights up the sentinel lymph node, demonstrates the channel which you're able to see along here, and you can see the lymphatic channel leading into the sidewall, leading into the obturator nodal packet, and where we would remove all of this tissue down there, we're able to target and just remove that one green lymph node that we were able to identify using that Firefly near-infrared technology. So we're able to significantly decrease the incidence of lymphedema in all of these sites, but especially in vulvar cancer, where that's a very high risk, and we're doing these groin node dissections. And in cervical cancer, this also identifies the highest risk nodes for the pathologist to evaluate. So that's kind of a little taste of what we do to provide precision surgical care. I think usually when we talk about precision medicine and targeted therapy and personalized oncology care, everybody thinks about systemic therapeutics and non-chemotherapy options for treatment of cancer. So that's kind of what we're going to focus on here. So when we talk about personalized medicine, what does that look like for each of our main disease sites? So for ovarian cancer, these are the kind of one-size-fits-all chemotherapy approaches. And you can see from the 60s all the way up to the 90s, 5 drugs were approved by the FDA for use in ovarian cancer. And then in the last 5 years, we have had an absolute explosion of targeted therapeutics, immunotherapy, PARP inhibitors, VEGF inhibitors. So we have a ton of these next generation therapeutics to choose from, even outside of chemotherapy. Chemotherapy is still the backbone of treatment for ovarian cancer, but we do have these new tools to use, these PARP inhibitors. They're an oral medication that's taken either twice a day or daily. They do have some side effects. They can cause bone marrow suppression, which may lead to either myelodysplastic syndrome or even leukemia lymphoma in very rare cases, but we have shown that this is not a significant increase over the baseline of just patients receiving chemotherapy. And they may cause nausea and vomiting, which is improved if taken with food or at night. So how do PARP inhibitors work? PARP inhibitors target this molecule called PARP, which repairs single-strand breaks in the double helix of DNA. Once this mechanism is inhibited, a single-strand break necessarily becomes a double-strand break because it can't be repaired. So if a double-strand break occurs, this repair mechanism for a double-strand break goes to the homologous recombination pathway. In somebody with a normal cell, that's repaired and the cell survives by homologous recombination. In somebody who has a BRCA or BRCA-like mutation, and for either BRCA reasons or similar reasons, has no ability to perform homologous recombination DNA repair, that's not repaired. And you've now knocked out two different mechanisms of DNA repair, and that cell dies. So these work great in patients with BRCA or similar mutations. So we have great data on these. In frontline maintenance, the kind of earth-shattering study was the SOLO-1 study, which came out now a couple years ago. These are BRCA1 and 2 patients. This was olaparib, which is a PARP inhibitor versus placebo, following maintenance therapy. That means after chemotherapy, with no evidence of disease, following complete response to frontline chemotherapy, 6 cycles of carboplatin and Taxol, and obviously the surgical management of ovarian cancer. And this is the survival curve, and this is extremely unique for us to see this dramatic of a difference. They didn't actually even reach median progression-free survival. So they never actually said, oh, our median progression-free survival was so many months. In the patients receiving the placebo, we knew it was 13.8 months. Those patients, half those patients recurred within 13.8 months. Over 50 plus months, not even half of the patients in this olaparib arm recurred. So this is amazing. And a dramatic change in how we think about ovarian cancer for those patients with BRCA or BRCA-like mutations. This is a similar study which included all comers. This is not as impressive of a survival curve because this included everybody, not just BRCA or BRCA-like patients. And this study looked at another targeted therapeutic, a VEGF inhibitor called bevacizumab or Avastin, along with olaparib in the maintenance setting, and showed also very impressive numbers. Again, this is not just BRCA patients. This is the entire population of the study, whether they had the mutation or not. And you can see a distinct advantage by adding the olaparib to the bevacizumab. So we'll kind of come back to ovarian cancer shortly as we talk about the importance of genetic testing, both in the whole body and in the tumor itself. But let's move over to endometrial cancer. What targeted therapeutics do we have that we can offer our endometrial cancer patients? One is Herceptin or trastuzumab, which is a breast cancer drug that is a monoclonal antibody used against the HER2 receptor. It's used in, we use it in uterine serous cancer that expresses this HER2 protein on the cell surface. And it targets those cells leads to cell death through a complex biologic mechanism. It's given in combination with chemotherapy. And in everybody in the study that got Herceptin added, the progression-free survival improved by 4 months. But if you just looked at previously untreated, new diagnosis, stage 3 to 4 uterine serous cancers, the patients that got standard chemotherapy had a progression-free survival of 9.3 months versus 17.9 months with Herceptin added. So that's essentially a doubling of progression-free survival by using the Herceptin in addition. And this is a well-tolerated drug with very few side effects. In recurrent disease, they saw a 3-month benefit. So there was still some benefit in patients that hadn't previously seen Herceptin. Additionally, in endometrial cancer, we have pembrolizumab, which goes by the brand name Keytruda. This is immunotherapy, which is useful for uterine cancer patients by itself with 2 different cellular characteristics. One is a mismatch repair deficiency, and that is a deficiency in another DNA repair mechanism. And the other is microsatellite instability, and this is a genetic problem that cancer cells can sometimes have, which makes them a little bit more unfamiliar to the rest of the body. And as in the last year, everybody in the country has kind of become an amateur immunologist due to our current pandemic. You know that cells that are recognized in the body as being foreign are able to be targeted by the immune system. In cancer cells, what prevents that from happening is receptors such as this PD-1, PDL1 receptor. So this is an immune cell here, this T cell, and it's providing the immune response to this antigen presenting cell, which is any cell really that is foreign. And this PDL1, programmed death ligand 1, joins with this PD-1 receptor and prevents the T cell from doing its job, because it then recognizes it as a self, as a native or self cell, and prevents it from attacking, prevents all the immune system from attacking it. If we block that pathway, that immune checkpoint, with an immune checkpoint inhibitor, the immune system can go and attack the cancer, and that's the main way that immune therapy works. We combine this with another drug called LENVATINIB or LENVIMA in patients that don't have either of these molecular characteristics, and we get a great response rate. So this anti-PD-1 pembrolizumab came out of 2 studies, Keynote 28 and Keynote 158, and the eligible tumors are all solid tumors, like I said, with deficient mismatch repair, microsatellite high, and if they were all previously treated with chemotherapy. So this is all in at least the second line. The response rate in that population, again, this is a subset of those patients, was a response rate of 57%. But look at this. Think about those other progression-free survival numbers. With chemo, we're talking like 6 to 12 months, and we get really excited about progression-free survival in that range. This is a 26-month progression-free survival on immunotherapy. So these are huge numbers that these immunotherapies put up, because they're able to induce the body's immune system to continue attacking these tumors and keep them from growing. The combination of lenvatinib pembrolizumab was approved last year, at the beginning of the year, and it's currently second-line therapy in patients who's everybody else who's not eligible, doesn't have that microsatellite instability, or doesn't have the mismatch repair deficiency. So it is a multi-kinase inhibitor that targets vascular endothelial growth factor. And basically what that does is prevents blood vessels from coming to the, from growing and being recruited to feed the tumor with blood and oxygen and nutrients. It's an oral medicine that's taken every day. The pembrolizumab is infused every 3 weeks. And the response rate with this combination is still pretty good for recurrent endometrial cancer. It's 39%. The duration of response, again, it's excellent, 21 months. There are side effects with the LENVATINIB, although we're getting better at managing those. That's diarrhea, hypertension. Those can be dose limiting, but we're becoming, in the last almost 2 years now of using this medication, or I guess a year and a half of using this medication, we've gotten a lot better at managing these side effects, and we're able to keep patients on this treatment for a pretty long time. So let's move over to cervical cancer. And our big targeted therapy in cervical cancer is also pembrolizumab, but it works a little bit differently there. Cervical cancer patients don't necessarily have microsatellite instability as much, or mismatch repair. We don't look for those markers. What we look for is whether or not there is PD-L1 positivity. In other words, if they have this ligand on the tumor. So if that's present, 14.6% response rate in those patients, which is not great, but here's what's great. Here's what is great. Median duration of response was not reached again in this cohort. So 3.7 months at the low end, up to 18.6. But over half these patients at 18.6 at the data cutoff time, over half these patients had not yet recurred. So this is a long response. If you get a response at about 15% response rate, these are patients that are going to respond for a long time. What's on the horizon for cervical cancer as far as personalized care and targeted precision medicine, non-chemotherapy? This is a drug for a trial that we recently opened here at Broward Health, and this is being used in patients who have had prior chemotherapy, may or may not have had prior pembrolizumab, and have metastatic or recurrent cervical cancer. This is a monoclonal antibody that targets tissue factor, which is highly expressed in many solid tumors, and it basically goes, binds to the tumor and delivers this antibody drug. I'm sorry, it is an antibody drug conjugate. So it delivers this drug, which is a microtubule disrupting agent, directly to those cells. So that it has minimal impact on the rest of the body, the clotting cascade. And we're very excited about the data that's come out in phase 2 of response to this medication. Really a great response rate and duration of response in patients who don't really have great chemotherapy options. So this is pretty exciting. We're really excited to have this trial open here. We were the first site in the world to open it in phase 3. So finally, I want to discuss the utility of germline and somatic testing in personalizing cancer therapy. And really, we could have put this as the second bullet, because this is sort of the foundation for how we get to these targeted systemic therapies. So in ovarian cancer, how do we decide who we can give a PARP inhibitor to? When do we give a PARP inhibitor? Who's going to benefit most? How do we personalize our care? So the key thing in ovarian cancer is basically as soon as diagnosis is done, genetic testing needs to be completed. So how does that look? Germline testing is the standard of care in all ovarian cancer patients, and that's what you think of, I think, most often when you think about genetic testing. And that's when Basically, you spit in a cup, it's sent off to a lab, and we determine the genetic deficiencies present in all cells in the body. This is what's inherited. This is what, when you find out if you have mutations predisposing for cancers. This is your BRCA, Lynch syndrome, Cowden syndrome, things like that. These predisposing syndromic mutations. This Fanconi complex, BRCA1, BRCA2, RAD51C, RAD51D, PALB2, and BRIP, these are all genes that, if deficient, have a similar effect as we talked about with a BRCA deficiency that knocks out that homologous recombination or homologous repair mechanism and allows the PARP inhibitor to completely destroy cells that sustain DNA damage. So once we have germline testing, obviously it's vital in the choice of therapy in the front line. And so we expeditiously test everybody. But then we also have testing, and we're able to do cascade testing, which is genetic counseling and testing of blood relatives. This is a key element of prevention for a very high-risk population. If you've got a daughter that's caring for her mother with ovarian cancer, watching what she's going through and saying, hey, am I at risk for this? Is this something that could happen to me? You're able to answer that question, and you're able to say, hey, we can do something about this. We can take your ovaries out when you reach a certain age, and we can decrease your risk for ovarian cancer. So baseline risk for ovarian cancer in the general population is 1.3%. BRCA, just to give you an idea of how these various mutations increase the risk, BRCA1 patients have a 40% risk. BRCA2 patients have up to a 20% risk of ovarian cancer. These other lesser known HRD mutations have up to a 6% risk. And then Lynch syndrome also carries not just a uterine and colon cancer risk, but it carries also an ovarian cancer risk as well, with a 5 to 10% chance of developing ovarian cancer. So what if the germline testing is negative? So if there's nothing seen on the germline testing in every cell in the body, then we look directly at the tumor tissue. We send the tumor tissue itself to a lab. We look for that homologous recombination or homologous repair deficiency, and we look to see if that mechanism would have stopped working just within the tumor tissue. If that's the case, that further stratifies patients who may benefit from a PARP inhibitor. Up to 50% of high-grade serous patients will have a targetable deficiency. So really, when you have an ovarian cancer patient, or if you are an ovarian cancer patient, there's up to a 50% chance that you're going to be able to receive that potentially curative frontline maintenance therapy with a PARP inhibitor and have a real benefit from it, like those patients in the SOLO-1 trial. The additional implications of tumor testing, which we send, is that it may also determine other cellular targets for novel agents, can direct us in how we select chemotherapy regimens in future lines, and the databases all have what trials are open for different mutations. So if they say, oh, this is a mutation that's kind of novel, we don't have therapy approved for it yet, but it's there, and this is a trial that the patient might be eligible for to receive this experimental drug that targets specifically that deficiency. So this is pretty cool, precision, next generation, exciting cancer care stuff. The future is, it's here. We're not just throwing one size fits all chemotherapy at all of our patients and hoping for the best. We're really targeting our care, and we're targeting more and more our care to be able to say, hey, this is going to work. I really feel that this is the right medicine for you. So all surgical specimens should be inspected in endometrial cancer for these mismatch repair genes. We talked about this being any deficiency in these genes might be make them eligible for pembrolizumab. It may also signify germline Lynch syndrome, so these need to be worked up. And next generation or somatic testing is done for microsatellite stability. So further determining who can get pembrolizumab and stratifying if they're getting monotherapy or if they're getting pembrolizumab with the Lenvima. All uterine serous cancers are also inspected for HER2 and to see if they can get trastuzumab or Herceptin in the adjuvant chemotherapy regimen and derive that benefit from treatment. So finally, cervical cancer, it's not a hereditary cancer. So we don't do germline testing, but we do somatic testing of the tumor. And this aids in treatment decisions. It evaluates for PD-L1 positivity, so we know if we can use pembrolizumab. And it may give insight into the use of clinical trial eligibility, like I mentioned before. So again, this is kind of everything we went over: surgery, targeted systemic therapeutics, and the way we determine those things by germline and somatic testing. I hope this was informative. Happy to take questions. Again, the era of one-size-fits-all oncology has ended, and we're able to really narrow and target our care and try and do the best we can for our patients, and it's really exciting where we're going.